Welcome back to AudioBoards. Today we're tackling a high-stakes topic that every clinician needs to master: adult seizure management. Seizure management is all about precision and timing. When a patient is actively seizing, your brain needs to run an automated algorithmic script. We're going to break this down into two distinct phases. Phase 1 is the acute crisis, status epilepticus, and phase 2 is long-term chronic management. Let's start with the crisis. How do we actually define status epilepticus today?
Historically, we waited 30 minutes, but operationally, we use the ILAE definitions based on two time points, T1 and T2. For generalized convulsive status, T1 is just 5 minutes. If a seizure lasts past 5 minutes, or if there are recurrent seizures without a return to baseline between them, the mechanisms that normally stop a seizure have failed. That is when you start aggressive treatment. T2 is 30 minutes, which is the point where prolonged seizure activity risks causing irreversible neuronal injury. 5 minutes is much shorter than people think when they're watching it happen. So, what is our immediate first line move at T1?
Your very first move is always basic life support, A, B, C, D, E. Secure the airway, check oxygenation, give high-flow oxygen, get IV access, and check a rapid fingerstick capillary glucose immediately. Hypoglycemia is an easily reversible mimic you cannot afford to miss. If they are actively seizing at the 5-minute mark, you enter stage 1, early status epilepticus. The first-line pharmacological treatment is always a benzodiazepine. If you have IV access, the gold standard is IV lorazepam, Ativan, typically 4 milligrams, which can be repeated once. If you don't have IV access yet, don't waste time fishing for a line while they're convulsing. Give intramuscular, IM, midazolam, Versed. 10 milligrams, or alternatively, rectal diazepam. The key here is adequate dosing. Underdosing benzos is one of the most common mistakes in the acute setting and just leads to treatment failure.
Right, don't be timid with the first line benzos, but what if that initial dose fails and they're still seizing at 10 to 15 minutes?
Then you immediately transition to stage 2, established status epilepticus. This calls for non-sedating second-line intravenous antiepileptic drugs, AEDs. You have 3 main first-tier choices here, given as a rapid IV infusion. Levetiracetam aka Keppra, typically loaded at 60 milligrams per kilogram, up to a max of 4,500 milligrams. Sodium valproate, loaded at 40 milligrams per kilogram, up to 3,000 milligrams. Fosphenytoin or phenytoin, loaded at 20 milligrams per kilogram PE. Recent large-scale trials show these three have roughly equivalent efficacy, about 50% success in stopping the seizure if benzos failed. Your choice depends on patient comorbidities. For instance, you avoid valproate in acute liver failure or suspected mitochondrial disease, and you avoid phenytoin if they have significant cardiac conduction blocks or bradycardia because it can cause arrhythmias.
Got it. Keppra, valproate, or fosphenytoin. Now, what if we've given the benzo, we've run the second line loading dose, and 30 minutes have passed, but the patient is still seizing?
Now you are in stage 3, refractory status epilepticus. This is a critical medical emergency. Once a patient crosses into refractory status, the guidelines are clear. You must immediately initiate general anesthesia, intubate the patient, and transfer them to the intensive care unit or neuro-ICU. Your options for continuous IV anesthetic infusions include propofol, midazolam, or thiopental/pentobarbital. The goal here shifts from just clinical control to electrographic control. You need continuous EEG monitoring to titrate these anesthetic infusions to either complete seizure suppression or a burst suppression pattern on the EEG for at least 24 hours before you attempt to taper them off. While you are doing this, you cannot ignore the underlying etiology. Status isn't just a disease, it's a symptom. You must aggressively investigate, run blood gas, electrolytes, especially sodium, calcium, magnesium, toxicology screens, check AED serum levels if they have a known history, and perform an immediate CT head. If there's any fever or altered mental status prior, a lumbar puncture is mandatory to rule out central nervous system infections like meningitis or encephalitis.
That makes total sense. Step 1 benzos, step 2 IV loaders, step 3 intubation, anesthetics, and an intensive diagnostic workup. But let's shift gears to the outpatient side or the patient who has stopped seizing. How do we manage epilepsy long term? When do we actually start daily maintenance medication?
That is the golden question. We generally do not start long-term antiepileptic therapy after a single, isolated, unprovoked seizure unless the patient has a high risk of recurrence. According to the ILAE, epilepsy is diagnosed and treatment warranted if there are at least 2 unprovoked seizures occurring more than 24 hours apart. However, you can diagnose epilepsy and start treatment after a single unprovoked seizure if the risk of recurrence over the next 10 years is high, specifically greater than 60%. We determine this high risk if the patient has a known structural brain lesion, like an old stroke, tumor, or trauma, an epileptiform abnormality on an interictal EEG, or if the seizure occurred during sleep.
So, a single seizure with a clean MRI and a normal EEG usually means we hold off and monitor. But if we do decide to treat, how do we choose the right drug out of the dozens available?
It comes down to tailoring the drug to the specific seizure type and the patient's profile. Broadly speaking, we categorize seizures into focal onset and generalized onset. For focal onset seizures, whether they stay focal or progress to a bilateral tonic-clonic, first-line options include levetiracetam, Keppra, lamotrigine, lamictal, oxcarbazepine, or carbamazepine. For generalized onset seizures like absence, myoclonic, or generalized tonic-clonic, you want broad-spectrum agents. Levetiracetam, lamotrigine, and sodium valproate are your heavy hitters here. A critical board-style pearl, narrow-spectrum drugs like carbamazepine, oxcarbazepine, and phenytoin can actually exacerbate certain generalized seizures like absence or myoclonic clones. So broad spectrum is safer if you aren't entirely sure of the onset type.
And beyond just the seizure type, I imagine comorbidities play a massive role in drug selection.
Absolutely. You choose the drug based on the patient's lifestyle and side effect profile. Let's look at a few classic clinical scenarios. Women of childbearing potential. This is a crucial area. Sodium valproate is highly teratogenic and causes significant neural tube defects and cognitive delays. It should be avoided in this population unless absolutely no other drug works. Instead, lamotrigine or levetiracetam are preferred due to much safer pregnancy registries. Elderly patients. They are highly sensitive to central nervous system side effects. Avoid highly sedating or anticholinergic drugs like phenobarbital or high-dose phenytoin. Lamotrigine or low-dose levetiracetam are typically very well tolerated here. Psychiatric comorbidities. If a patient has severe depression or anxiety, levetiracetam can cause behavioral side effects, colloquially called Keppra rage, irritability, mood swings, or worsening depression. In contrast, a drug like lamotrigine has mood-stabilizing properties and might kill 2 birds with 1 stone. Conversely, if a patient suffers from chronic migraines or obesity, topiramate, Topamax might be an excellent choice because it helps prevent migraines and promotes weight loss, though you have to watch out for cognitive slowing or word-finding difficulties.
This really highlights why personalized medicine is so important in neurology. What is the fundamental strategy when titrating these medications?
The golden rule of epilepsy management is start low and go slow, aiming for monotherapy. You want to titrate a single drug up to its maximum tolerated clinical dose before you declare it a failure. If the first drug fails due to side effects or lack of efficacy, you bring a second drug up to a therapeutic level before slowly tapering off the first one. We only move to combination therapy using 2 or more AEDs if sequential monotherapy trials have failed. When a patient fails 2 appropriately chosen and correctly dosed AED schedules, they meet the definition for drug-resistant epilepsy. At that point, simply adding a third or fourth medication has a very low probability of rendering them seizure-free. You must refer them to a comprehensive epilepsy center to evaluate for non-pharmacological interventions such as resective epilepsy surgery, a vagus nerve stimulator, or a ketogenic diet.
To close things out, what are the non pharmacological counseling points we must give every patient diagnosed with epilepsy?
You must address safety and lifestyle. First is driving restrictions. This is legally mandated and varies by state or country, but typically requires a seizure-free interval ranging from 3 months to a year. You must explicitly document this discussion in your note. Second, discuss trigger avoidance. Strict adherence to medication schedules, avoidance of severe sleep deprivation, and moderation or avoidance of alcohol, as withdrawal can precipitate breakthroughs. Finally, educate them on seizure first aid for their families and discuss the rare but serious risk of SUDEP, sudden unexpected death in epilepsy, emphasizing that taking medications consistently is the best way to mitigate that risk.
Perfect. Let's pivot to a major diagnostic challenge: patients with events that look exactly like seizures, but their EEGs are normal. What do the latest guidelines say about managing what we historically called psychogenic non-epileptic seizures, or PNES?
The guidelines have shifted significantly, starting with the name. We now use the term functional seizures. Psychogenic carries a heavy stigma for patients. A great clinical analogy is to explain it as a software glitch rather than a hardware issue. In epilepsy, the brain's physical wiring has a problem. In functional seizures, the hardware is perfect, but emotional stress or trauma causes the operating system to temporarily crash and dissociate. The events are entirely real and involuntary. They are not faking.
That software analogy frames it perfectly. How do we definitively prove the diagnosis?
The gold standard is video EEG monitoring, VEEG. You must capture an episode on camera while recording the surface EEG. A functional seizure will show classic physical movements, but a completely normal background rhythm with zero epileptiform discharges and no post-ictal slowing. Just watch out for a major clinical trap. Epilepsy and functional seizures are not mutually exclusive. Up to 20% of patients with functional seizures also have true coexisting epilepsy.
A fifth of patients have both. Good to keep on the radar. What physical signs point toward a functional etiology before VEEG?
Look for these classic semiology clues. Eyelid resistance, tightly closed eyes, actively resisting you opening them, asynchronous movements, out of phase bicycling or limb flailing, and side to side head shaking, pelvic thrusting, forward thrusting or severe back arching, waxing and waning, episodes that stop and restart, often lasting much longer than a typical 2-minute epileptic event.
Once confirmed, what's the treatment strategy? Do we keep them on anti-seizure meds?
No, you should slowly taper and deprescribe unnecessary anti-seizure medications. They provide zero benefit and cause iatrogenic harm. Interestingly, how you deliver the diagnosis is the first line of therapy. Compassionate communication that validates their symptoms while explaining the functional mechanism actually leads to 1/3 of patients becoming entirely seizure-free without further treatment.
That's incredible. For the others, what's the next step?
The absolute gold standard is specialized psychotherapy, specifically cognitive behavioral therapy, CBT, tailored for functional neurological disorders. Because trauma and PTSD rates are exceptionally high here, trauma-informed therapies like prolonged exposure or EMDR are highly effective. Use pharmacology strictly to treat underlying comorbidities like SSR is for severe anxiety or depression.
Finally, how do we handle an acute functional episode in the ER to prevent unnecessary intubations or toxic drug loads?
Every patient needs a crisis de-escalation plan. If they present in pseudostatus, teams often mistakenly slam them with massive doses of IV benzos or sedatives. Instead, protect them from injury, minimize panic in the room, and do not give rescue benzos. Because most patients retain auditory awareness during a functional event, speaking to them in a calm, quiet, grounding voice is actually the most effective way to help them terminate the episode. Thanks for listening to AudioBoards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the AudioBoards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified, board-certified healthcare provider for any medical concern.